So welcome to Clear Week 2023. This is an event when we're sharing the findings and learnings of our Clear transformation projects. This is our second session of day one. It's called Clear Ophthalmology, Designing a New Model of Care at Sussex Eye Hospital to Tackle the COVID-19 Backlog and Reduce Waiting Times. Thank you very much for joining us. Please note today the session will be recorded so we can share it with others afterwards. Please feel free to share your thoughts on social media. We're using the hashtag #ClearWeek, and our handle is @Clear4Care. They will be put in the chat. So our speakers today are Lisa McManus, Project Lead for Ophthalmology at NHS Sussex, welcome, and Dr. Eve Corner, who is our Ophthalmology Project Clinical Lead for the Clear programme. Unfortunately, Dr. Saul Rajek, who has been called away clinically today, so is unable to join us. Over to you, Eve.
Hi everybody, welcome to this session. What we're going to do in the time we have is just talk you through we'll set the scene in terms of the ophthalmology project that we did in Sussex, talk you through the clear methodology and the project outcome in terms of the recommendations and the new models of care and workforce. And that should probably take us about 20 to 25 minutes to give us plenty of time for any questions that you might have afterwards. If we could just move on to the next slide, please. Thanks. And the next one. So yeah, as we've Caroline has said, the webinar is to share the learning and the outcomes that resulted from the Clear programme that we did down in Sussex. We wanted to try and share this from multiple different perspectives. So Lissa's kindly going to talk a little bit about the ICS perspective in terms of what the problem was. I'm going to then talk about the methodology and the results of the programme of work that we did. And Saul has kindly provided a slide to offer some reflections and some narrative for me just to kind of feedback on his experience of working with the Clear team. And then, as I said, we'll have lots of time for questions at the end. So if we move on to the next slide, and I'll hand over to Lissa to set the scene.
Hi, good afternoon, everyone. So my name is Lisa McManus, and I'm the ophthalmology lead for Sussex ICB. So thanks a lot for inviting me along to speak today. So to start with, I'll just give you a bit of background of where we were at the time we asked for Clear's help. Ophthalmology was already a specialty that was battling with a growing waiting list pre-pandemic, and with an ever-growing ageing population that is just growing year on year. Which means the risk of developing an eye condition is already on the rise. The COVID pandemic compounded this issue even more. And although we chose to focus on ophthalmology due to the challenges we're particularly having across Sussex, many of these challenges are being faced by other specialties too. So all the workforce across the NHS have been pushed to the max during the pandemic, and as services are returning to their pre-pandemic levels of activity, there's now additional pressure to clear some of the large backlogs that have been created or may have already been there pre-pandemic. And we're asking more and more of our staff, and they're already working additional shifts for prolonged hours, and quite frankly tired, and morale is quite low. So our hospitals and specialties across the system are all different. Some of them have quite sort of specialist units, and others have sort of much larger populations that they cover. So we felt that we found it very important that we investigated each issue at each of the different providers and provided a tailored plan to each one instead of trying to impose a kind of one-fits-all solution across the whole of Sussex. So the sort of specific issues that we had at the Sussex Eye Hospital was a large backlog, which was caused by the increase in demand with the ageing population, and also because services were reduced and suspended during the COVID pandemic. We asked Clear to come and review Sussex Eye Hospital, which is a kind of old building and has quite a lot of physical constraints. And there's currently, you know, from what we can see, no room to kind of expand the service, which is needed. And patients are being treated in, you know, less than ideal circumstances. Due to it being a really busy department, and with all the kind of backlogs and the extra working, there isn't really time for staff to step back and review the service and reflect on current processes and issues. So, you know, there is that feeling of we're just doing more and more and more of the doing and not able to reflect on what could be done differently that might help people. There's workforce challenges across the department, which I think you're seeing across the whole of the NHS. And the staff that we have got are working overtime and, you know, coming in on their days off to make sure patients are seen. So, you know, they're kind of doing the max they can possibly do. And the department also has a bit of a kind of negative experience of management consultants to date. There has been that kind of feeling that people come in and just tell them they need to do more of what they're doing. And, you know, their lists are already full, they're already doing to the max. So we needed a kind of bit more innovative solutions rather than just more of the same. So what we kind of needed and asked from Clear was some evidenced solution to address our rising demand. And this was to look at kind of current processes, our estate's capacity, and also our workforce capacity. And we could use that then because we have the evidence to build kind of business cases to support change going forward. One of the things that was particularly important to us is that we built a solution that was practical and doable, based on the realities of what's happening at Sussex Eye Hospital. And as I said, not just that kind of one fits all across the whole of Sussex. And, you know, we wanted to build a solution that responds to the kind of evidence of what's going wrong and what the issues are, and that engages everyone in the process. So, you know, our management and especially our clinical teams are at the, you know, front end of this, and that they are the ones dealing with it every day. So it's really important that they are engaged in the process. So I'll hand back over to Eve to tell you what Clear did.
Thank you. Move on to the next slide. So let me just give you a bit of context as to what Clear stands for, how Clear works in terms of a methodology, because I'm conscious some people may not be familiar with what Clear is. So Clear itself stands for Clinically Led Workforce and Activity Redesign, and we've sneakily stolen the E from workforce to give ourselves a nice acronym. It's a programme that is sponsored by Health Education England, and it was developed by clinicians for all clinicians. So it was recognised by the founders of the company that once you get to the right person in the NHS, then you can have really good care. But actually, there's a lot of issues with the way that systems are working and the way that patients flow through those services that could be improved. And actually, clinicians on the whole have the answers to that, but they don't necessarily have the headspace or the data to create a cogent business case for change. Clear as a programme in this case was a co-design approach where the Clear faculty, who are clinicians as well, but also trained in the Clear methodology, worked very closely with the team at Sussex Eye Hospital to develop new models of care that were grounded in local data, address local issues, and were realistic, recognising the different demands on those clinicians and factoring them into our workforce modelling. The methodology itself, it has 4 stages, and it's based on a medical ethnographic type approach. So it's a mixed method type of, well, research for want of a better word. But the first stage of it is clinical engagement, and this is when we go out and talk to staff. So we spend a lot of time within the hospitals or the primary care networks or wherever we're working to really build relationships and understand the issues that are pertinent to that service. And this creates a good foundation for us to really work in a co-design approach to develop new ways of working that are solution driven and that are brought into by the clinicians that are already working in that service. Whilst our clinical team are doing a clinical engagement, our data team are busy extracting data from the systems, and this includes workforce, clinical and finance data. And that data is validated and cleaned and built into data dashboards. And this enables us to visualize the patient flow through a service essentially and do an in-depth cohort analysis of the patients. And for this particular project, we took data from about 8 different sources into our dashboards, and that included the the ED, theatres, wards, as well as Medisoft, which is the ophthalmology specific software, as well as some manually collected data that was stored in Excel spreadsheets. When we've got the clinical engagement data, we do a thematic analysis of it, and we take those themes together with the outputs of the data interrogation into an innovation stage where we come up with solutions. And during that innovation, we come up with not only the solution, but we also look at the workforce required to deliver that solution and the impact that that new model of care would have in terms of patients, staff, and finances. We then finish that with a report, and that report comes in the form of a written report, but also an oral presentation to the exec team, case studies, and further broader dissemination. If we just move on to the next slide. So the idea with the CLEAR programme is really, as I said, that it was developed for clinicians, by clinicians. And what we're really trying to do is develop those new ways of working, develop a clinically led culture so clinicians feel they have some autonomy and control over the destiny of their service. Try and impart some new skills around how we do the CLEAR approach, and ensure that everything we develop is very much clinically owned. Next slide, please. So I'm going to move on to the results of the ophthalmology project. So our scope with this project, to give some context, wasn't just was looking at 3 different pathways. So we looked at cataracts, glaucoma, and the medical retina pathways. And we started our clinical engagement with several site visits. We spent about a week there in total. And during those site visits, we did interviews with staff. We did clinical observations where we followed patients through the service. We sat in clinics with the consultants. We looked at the documentation they were using, and we talked to the administrators and looked at how things like lists were planned. And this, in total, we spoke to 40 staff members, and it gave us a wealth of qualitative data, which we then transcribed, took notes on, and analysed using this thematic approach. This data was really focused on the issues with estates, workforce, systems, patient flow, and staff perception of issues. From this data, we then condensed that down into themes, and the 5 key themes that came out of this particular project are listed on the slide. So the first one was opportunity to improve processes and ways of working. And I'll give you an example of that. One of the processes we recognised that could be improved was around the stratification of lists within the cataracts clinic. There was a desire to try and integrate some HVLC lists into within Sussex Eye Hospital, but actually within clinic there was no way of stratifying the patients that were appropriate for those HVLC lists in order for them to be booked in and to organise the lists in that fashion. The resource deployment wasn't always aligned with demand, and this was seen kind of in 2 ways, I suppose. One was that there was a lot of people working a lot of overtime, particularly for referral refinement. And there needed to be a kind of change in the workforce in order to make sure that they weren't getting burnt out. But also there was some redundancy within some of the clinics with kind of multiple support staff, nursing staff doing multiple tests that potentially could have been streamlined. There was opportunity to improve IT infrastructure and data collection. As I said already, we integrated data from 8 different sources for this project, which I think might be a record. And actually, with improved IT infrastructure, it would reduce the administrative burden and make things just run a lot smoother, and also reduce risk of any lost manually collected data that was actually quite important data that they were putting into spreadsheets. This was being addressed to a degree with the integration of Open Eyes, which is happening shortly. Theme 4 was around the headspace to think strategically and a sense of disempowerment. And I think Lisa alluded to this a little bit earlier on when she talked about this. Everyone is working so hard and so busy that actually to stop and think about how things could be done better, they just didn't have the time for it. And there was this sense of disempowerment from, previously having consultants come in and those initiatives not really leading to much change within the service. And the final theme was around the health and safety risks, and this was particularly around the data and estates. Data in the sense that there was some key clinical information that was being recorded on manual spreadsheets that actually would be useful to have in a kind of proper IT infrastructure. And in terms of estates, they're a very old building, lots of patients waiting in the corridor, which could have caused problems with evacuation, for example. So the estates really needed to be optimised. So we'll move on to the recommendations. And what we've done for this project is to group our recommendations into two groups. So the first is around cataracts and theatres, and the second is around outpatients and workforce. So the issues within cataracts were the waiting list. So the waiting list was very long. Theatre waiting list was 800 patients and the clinic waiting list was 900 patients. And what had happened as a result of these waiting lists was that the hospital had made a contract with the private sector to send 35 patients a week to the private sector to help them get through that backlog. This was a concern to the commissioners because of risk of double paying, essentially, because it's a block contract at the hospital. What we wanted to try and help Saul and his colleagues do was to try and meet the demand for cataracts in-house, to try to clear the waiting list, and ultimately to try and phase out the private sector contract within the trust. So they were the goals, and what we wanted to look at in order to do that was the capacity and demand, list planning, theatres and the estates. Move on to the next slide, please. So the recommendations that we came up with, there's 6 key recommendations. The first one was around the number of cataracts clinics per week. There was an average of 60 referrals for cataracts per week coming into the trust, but there was on anywhere between 1 and 5 clinics running per week, meaning that between 12 and 72 patients could be seen on a weekly basis in the CAC. And this just simply wasn't enough to meet the demand. This was in part due to things like annual leave, but also could have been improved with some job planning. So our first recommendation was around having a consistent number of cataracts clinics per week and increasing the number of patients back within those clinics back to pre-COVID levels. This could be done by either having 3 or 4 consistent clinics, depending on the number of patients that come through it. The second recommendation was around the stratification of theatre lists to integrate these high volume, low complexity lists. Really fundamental to this was that that we factored in standard and complex GA lists as well. The ophthalmologists are having to do a lot of training for their trainees coming through. There's reports that they often get left with the more complex patients because opticians will send the kind of simpler cases straight to the private sector, and you can't work at 100% all of the time. So it was really important that we looked at how we stratified to integrate different types of lists, high HVLC lists for patients that could be on HVLC lists, and standard and complex lists for those more difficult patients and those training opportunities as well. To do this, the first solution is quite a simple one, really. It's around the integration of the risk stratification tool for cataracts within the clinic to allow planning of those lists in an appropriate fashion. And actually with the integration of Open Eyes, there's the functionality within that system to enable that to be done in a digitalised fashion. And the second was around the homogeneity of the cataracts lists. What we were seeing was that cataracts lists were often mixed with other procedures. And if you could increase the homogeneity of those lists, particularly for the HVLC, you'd be able to have a much speedier throughput through theatres due to not having to change equipment, etc. The third recommendation was around a cataracts case manager. On average, there was 1 cancellation per list that wasn't being filled because there was no last-minute list. There was no system, to fill last-minute cancellations. We recommended these for the cataracts case manager. This had been worked really well in other departments within Sussex Eye Hospital, particularly within the medical retina service and the orthoptic service. And the role of that case manager would be to support the filling of last minute cancellations, but also to support in the CAC clinic to avoid any, to prep any patients that may require social support on discharge and avoid any need for admission. The fourth recommendation was around the starting of lists on time, and there were so many factors that contribute to starting lists on time. But what we were seeing was actually the morning lists weren't starting until around 9 a.m. and the afternoon ones until 2. So if there was anything that could be done to ensure that these lists could start on time, then you could squeeze in an extra cataracts onto those lists. what we agreed with the team was this, to develop a set of preoperative standards, and this is particularly for the pooled HVLC lists, so the simpler cases, because what was happening was that the consultants were going to do a morning ward round to review all of the patients, sometimes not always agreeing on the surgical plan. So particularly for those simple cases, if a set of standards could be agreed for those pooled surgical lists, it may speed things up at the beginning of the day, especially if that was combined with a nurse or trainee-led consenting clinic. The fifth was around the administrative burden in theatres. So there was a requirement to fill out two letters, write 2 letters at the end of the surgery, discharge letters, on 2 different note systems, and then print them out and put them into the medical notes. And the printer often broke, so there was a lot of slowing down within the theatre setting because of that administrative burden. So we recommended the integration of a scribe into theatres to allow the surgeons to operate essentially and speed up that administrative processes. And the final recommendation was around the actual capacity demand in terms of estates. What we looked at is how many theatres, if you use the risk stratification that we've got in terms of the stratification to different types of theatre lists, how many theatres would you actually need to run if you just did cataracts to meet the demand that was coming in? And we came up with a few different options for 2 permanent cataracts theatres to try and meet that demand. And with the stratification, I forgot to add, with the stratification, what we were actually able to do was reduce the number of lists each surgeon had to do. So we provided a few options for those in terms of the estates that are being looked at the moment. Now the next slide, please. So in terms of the forecasted impact, the stratification alone allows a reduction in the number of lists whilst also meeting the demand. So we from the calculations looking at the number of referrals coming in, you could reduce the list from 29 per calendar month to 19. We also recognise that you would be able to phase out this private sector contract by meeting the demand in-house. The number of lists per whole-time equivalent per month would reduce from 4 to 2.5, and the review of the theatre estates could release Sussex Eye Hospital resources to manage the more complex cases that could be done in the main Sussex Eye theatres that has access to the acute hospital for those more complex surgical cases that they do there. Having a case manager to fill that lost theatre slot alone would save £250,000 per year of lost theatre time. So I'd move on now to the recommendations for outpatients and workforce. So in terms of outpatient service, we were looking at a few different outpatient services, but the example here I'll talk to is the glaucoma, because this was the biggest problem. There's over 7,000 people on the glaucoma waiting list at Sussex Eye. And if you wanted to try and meet that demand with the current model of care, you'd have to scale it 2.5-fold. This was just not going to work for a number of reasons. The associated costs were very high. The workforce availability in terms of ophthalmologists just wasn't there. And what we were actually seeing within the data was that there was an increase in the number of severe and advanced glaucoma patients presenting to clinic. Before COVID, this had consistently been, for 3 years, 2 patients per week. Since COVID, that had consistently risen to 5 patients per week. So it appears that there is potentially avoidable disease advancement, so it really needed to be addressed within the modelling really needed to be done within the glaucoma service. We wanted to make sure that the capacity met the demand, improve efficiency, reduce this backlog, but most importantly, reduce any avoidable disease advancement. And the next slide, please. So in terms of the recommendations, the first one, which I'm going to jump over a little bit because it's really about the immediate interventions, and the immediate initiatives we recommended were a priority month for waiting list validation and the use of asynchronous and virtual clinics to try and make sure that the patients were seen. But the bigger one really is the long-term plan in terms of the glaucoma care. And what we recommended is the phased integration of a cross-hospital and community glaucoma service. So there are lots of community glaucoma services in England, And there's been some non-inferiority studies, particularly for the COGS service in Oxford, that showed that patients could be well managed within the community by community opticians for stable and mild glaucoma. But there's been some concerns about these approaches as well, because of risk aversion. There's a concern that if an optometrist that is working in the community may refer on to ophthalmology despite having seen the patient because their risk threshold is lower, essentially. And so that actually creates more work. And we wanted to avoid that. So working with the team, we came up with this idea of a cross-hospital and community glaucoma service. And this is when the way that this would work would be that the community optometrists would be trained up in the glaucoma certificate and come and work in portfolio careers. So they'd be working cross-system with a few days working within the HES system, and then also staying for the remaining time in their community clinic. As they're training, as they kind of graduated through the 3 levels of the glaucoma training, these clinics could be migrated out into the community, and the staff would have a rotational system where they'd work both within the community setting and the HES system to ensure that continuity of communication, continuity of training, and reduce the risk of risk aversion, I suppose. Fundamental to this pathway is a few different elements. So one of those is the electronic eye care referral system, which is EERS, which is already being implemented and piloted within Sussex. And this is a referral system that allows direct referral from the high street optician to the ophthalmology department. Fundamentally, it has full transfer of the whole OCT imaging, so could reduce the need to repeat that imaging, particularly in cataracts cases where it's more of a rule out imaging that's completed. This also allows a 2-way dialogue between the ophthalmology department and the high street opticians, so that you can facilitate referral refinement, and obviously cuts out the need for the GP to be involved. We recommended job planning for the referral refinement so that the staff weren't working in their spare time having to complete this. The co-location of an on-site diagnostic hub within an area that was currently used for administration. And the upskilling of different staff to work in this role. And this could be optometrists, but also could be orthoptists and ophthalmic nurses as well. The final 2 points are around the integration of the CSER programme, so the Certificate of Eligibility for Specialist Registration, to try and get more trust grade doctors, and a review of the actual clinic flow itself with optimisation of the waiting area that was being underutilised with patients waiting in the corridors instead. But reviewing that flow through the clinic so that the patients weren't there for as long, because they were there for a good few hours, and we wanted to try and speed that up. We move on to the next slide. So this is an example. There's other examples within this project, but an example of how we do our workforce modelling and the impact of this new integrated, we're calling it SIGS actually, Sussex Integrated Glaucoma Service, and what that's composed of in terms of the workforce. So on this table, what you can see in the top row is the current workforce model. The second row is the current model if it was scaled to meet the demand. So what you would need if you use the current model, but you were trying to meet that 7,000 patients on the waiting list. And the final row is the new model of care workforce model. So what you can see is that with this new model of care, we've recommended a reduction in the number of consultants within the service, and they would be really focusing on the surgical cases, the unstable cases, and the more complex cases. But with that, there's an increase in the advanced practice role. So particularly opticians, orthoptists, and ophthalmic nurses who could fulfil that role, creating career opportunity and facilitating retention as well. A slight increase in the number of fellows and trainees, and a reduction in the number of nurses and HCAs by streamlining that process within the clinic itself. Overall, the new model of care that we're recommending is still more expensive than the current model of care that isn't meeting demand, but it's a lot cheaper than what the current model of care would cost if it was scaled to meet demand. So in that situation, you'd be looking at nearly £2 million per annum. But with this new model of care, that reduces to just over £1 million per annum. We move on to the next slide, please. So in terms of the impact of these recommendations around outpatients, workforce, and particularly glaucoma, if we can meet this demand, and get through the waiting list and ensure that patients aren't waiting 53 weeks, which was the current wait time, it would reduce this risk of avoidable disease advancement, and we were seeing that in roughly 150 patients per annum. We're optimising the workforce here and creating career opportunities as well as optimising estates. And there's a cost saving as well from the integration of the EERS system by reducing the demand on the OCT scanner within Sussex Eye Hospital. And finally, we are ensuring that capacity to meet demands at a cost of roughly 1 million, which is around 835,000 lower than the alternative. And these costs could actually be met by the savings that would be created from the cataract service. Just move, yeah, and on to the next slide, please. So in summary, the recommendations that we've come up with will hopefully clear the backlog on the waiting lists, reduce the number of cataracts lists required, which has a significant saving in terms of staff time, but also a financial impact. Integration of this last minute list will avoid lost theatre time, that was looking at around 250,000 per annum, lower imaging costs, as well as diversification of the workforce and optimisation of that workforce, and remove the need for the private sector contract between Sussex Eye Hospital and the independent sector in the region. And finally, the new model of care that we're looking at is around, as I said, 835,000 per year less than scaling the old model with 50% fewer consultants who are focusing their time where it's really needed. The next slide is just one that Saul's provided, I believe. Yeah, as Caroline said, really sadly, he's been pulled away to clinical work today and can't attend, but he normally does this presentation with me and offers some quite honest, candid insights. So it's a shame he's not here, but I'll try and condense what he would have said. I mean, his experience of working with consultancies hasn't always been the best, but he has found that working with the Clear team has been very clinically led, very engaged with the clinicians, thorough, productive, constructive, but also enjoyable. We're working now with Saul and the team to look at how we can support implementation of some of these recommendations to ensure that they get implemented as soon as possible. And Lisa and her team are also working on that in terms of the glaucoma pathway as well. So I'm going to end the presentation there. I'm very happy to take any questions. I don't know if Lisa's got any further reflections that you want to add from the system, but no pressure if you don't. But happy to take questions.
Many thanks,
Yeah. I'll just say that, yeah, we're having the same feedback as Sol has given. Any presentations that Eve has come to give. As always, we're getting lots of, please can they now come over to us as a provider. So we're currently have put together a business case where we are trying to get Clear to go to our other providers to look at our other ophthalmology services, but also to have a look at some of our other specialties as well, such as ENT.
Lovely, thank you. Thanks, Lisa. Any questions? Alex.
Thanks, Lisa and Eve. It's really interesting hearing about the work. I have a bit of a question for both of you about what you found the most interesting or surprising thing about this project. If there was anything that kind of came out at you that was a bit of a surprise, either about the way that it was done or the findings that you came across.
I'm just reflecting and trying to think what was the most surprising. That's a good question, Alex. I'm struggling to come up with an answer. I think the most difficult thing, maybe not that surprising, was that the ideas were all there, and there was some really good examples of really innovative care that were being used, particularly in the ED department and the medical retina service, with really good diversification of the workforce, optimization of roles. They have a consultant optometrist within Sussex Eye Hospital who is there to try and promote that career pathway. So in some ways it was quite nice because we could kind of talk to them and see how they'd work through their workforce issues and come up with that model of care. But I suppose, yeah, the ideas, a lot of them, it was very much about having the headspace to come up with that narrative, and having the data to support the business cases. That was the key thing. But yeah, I suppose they're my initial thoughts off the top of my head.
Lisa, did you want to add anything to that?
No, I think I agree. I think there's a there's a good team there who definitely have strong views on how to take it forward, which are great ideas. But yeah, it's just the challenge of getting that across the line as well, and being able to take it forward. It's especially we've been concentrating quite a lot on glaucoma, and we do have some ideas, but it's very, very challenging to move forward and see that change happen. So really.
Yeah, the nice thing about this project, I think, has been the relationship that we as a Clear team have built with the clinicians, and how much co-design has gone into it, and how collaborative it's been, which has been really nice to kind of work in that way with them.
Eva, I had a question about, you mentioned the private sector being phased out. How soon do you think that could happen? Do you have any timescales?
Well, I don't think the private sector will be phased out altogether, but the contract between the hospital and the private sector can be phased out. So our recommendation was actually to keep them for the short term until they'd managed to implement the recommendations. The contract was up for renewal in January, and I am yet to know what the outcome of that was, but the goal would be to have that gone within 6 months. But it would require these the efficient processes to be put in place, particularly around the clinic, the increase in the number of clinic numbers. But yeah, our recommendation was to phase them out within 6 months and to integrate this new approach. But actually, in the short term, it was quite handy having that there in order to get them onto an even keel to then kind of press reset and start with this new model of care and new strategy.
Becky has put a question in the chat saying, was there an outcome or positive following the project which you were particularly pleased about or felt proud to have helped accomplish?
I think that the work we're doing now, so off the back of that project, Lisa's just kind of alluded to, we have come up with an offer to look at how we could integrate the SIG service across the whole of Sussex. And I'm really excited about that, because I think it's a really promising offer that could actually change the whole pathway for glaucoma care across the whole county. So I'm really hoping that gets over the line, because I think if we can move forwards with that, it would be a whole pathway redesign at county level that could be mimicked probably nationally.
Any further questions from anyone? Could you just wrap up? You've already alluded to some points about next steps. What would be, or perhaps Lisa can just explain where do you go in the next few months?
So some of the smaller recommendations are being implemented. So the integration of the open eye system will allow risk stratification of the patients, and I believe a case manager has been recruited for the cataract service as well. So those two kind of simpler recommendations have been moved forwards. Lisa's got working on the integration of the ERS system, I believe. Is that right, Lisa? So the first step.
It's already started at Esht, but obviously that needs to be then implemented across the whole of Sussex.
Yeah. So those, and also the other thing that's happened is the clinic review has happened. So the review of the patient flow through the clinic, and given that the report was only finished in January, the fact that those full things have been actioned already is really promising. I think in terms of our next steps, as I said, we're trying to work with the system to create an offer to support implementation of the cataracts changes within Sussex Eye. So we've put in a proposal to help with that. Because again, it comes down to this headspace to actually keep things moving, and I think that speed is essential, and momentum is essential in these kind of projects. And we're working with the team at Sussex Eye, the transformation team at Sussex Eye as well, And yes, and we've put in for some funding to look at this system-wide integration of the glaucoma service, which could completely revolutionise the glaucoma care across the county. So it's all very exciting. It's an exciting point in the project.
Lovely, thanks you both. Well, if there aren't any more questions, just for me to say many thanks to our speakers and everyone who attended today.